Hello everyone, my name is Gina and this video is going to be about a simulated lactation consultant with a patient named Maria who is 3 days postpartum, who delivered vaginally without any complications and is attempting to exclusively breastfeed. She comes in with reporting of significant nipple pain, a shallow latch, and cluster feeding with concerns about an inadequate milk supply. The infant is healthy and appropriate for gestational age in weight and height and has transitional stools with about 3 to 4 wet diapers per day. The mother's main goals are to exclusively breastfeed and learn how to feed comfortably and effectively. When assessing this case, there are several maternal and infant factors that are contributing to these breastfeeding challenges. The mother's symptoms with nipple pain during the feeding, and also the lipstick nipple shape after feeding strongly suggest a shallow latch. The frequent feedings and fussiness after feedings may be related to an insufficient milk transfer, not necessarily a low milk supply. The infant's diaper counts and stool progression towards a transitional yellow appearance and appropriate weight trajectory all support that milk production is normal for day 3 postpartum. Cluster feedings at this stage is expected newborn patterns as milk transition matures. Research reinforces this, that an ineffective latch and positioning are common in early postpartum mothers. One study found that fewer than 1/3 of new mothers demonstrated an effective latch technique without targeted guidance, highlighting the need for more hands-on guidance during the early postpartum period. Based on this assessment of this mother, Maria, the priority issues include a shallow latch, maternal nipple trauma, insufficient milk transfer, cluster feeding interpreted as low milk supply, and high maternal anxiety due to the pain and perceived insufficiency. My primary goals during this lactation consultant are to address her pain, improve latch effectiveness, and promote infant satiety, and also build maternal confidence. I want to teach and demonstrate deep latch techniques, including aligning the baby's nose to the nipple to promote for wide mouth opening, holding the infant belly to belly for optimal alignment, guiding the nipple towards the roof of the infant's mouth, and ensuring that the lips are flanged and the chin touches the breast. I would then review feeding cues such as rooting, hand-to-mouth movements, and quiet alert states. The mother would be taught to breastfeed from about 8 to 12 times in 24 hours and respond to cues rather than feeding schedules. Cluster feedings would be normalized as typical during days 2 and 3 as the supply increases. Breastfeeding needs an increased caloric intake by approximately 300 to 500 calories per day. I would also encourage her to drink enough fluids to satisfy thirst, eat balanced meals, and rest as much as possible during the cluster feeding periods. When latch connection is the cornerstone of treatment, I would also introduce comfort measures that are also supported by evidence. In a systemic review, I found that also moisturizing therapies such as the use of lanolin or even expressed breast milk on the nipple can support healing of nipple trauma through moist wound principles. These treatments can be used adjunctively while working on improving latch technique. If the infant is still struggling to latch, or if the breasts feel overly full, I would teach and encourage the patient to potentially use hand expression or use breast pumps as well to maintain the comfort and protect the milk supply. When the patient does have an adequate amount of milk supply, storage guidelines are very important to follow. Breast milk is able to stay 4 hours at room temperature, 4 days in the refrigerator, and up to 6 to 12 months in the freezer. The milk should be labeled in clean packages and stored in the freezer for later use. Another article I found emphasizes the importance of culturally responsive, equity-focused breastfeeding education. I would tailor the teaching to the mother's cultural beliefs, literacy level, and feeding goals, ensuring that the education feels supportive, respectful, and empowering. This would include asking about beliefs and about her feelings, ensuring that the education goals are clear, non-judgmental, and aligned with her values, supporting her with this goal of exclusively breastfeeding, and also using evidence-based strategies to help guide her. With this patient, I would use active listening, and I would also try to affirm her efforts and her goals throughout the breastfeeding process, as it may be very difficult, especially if this is her first child. I would use non-judgmental language and encourage shared decision making when educating her on breastfeeding techniques. This therapeutic approach promotes maternal confidence and support through continued breastfeeding. This lactation consultation highlights the importance that combining clinical assessment, evidence-based strategies, and therapeutic communication to support breastfeeding and help the patient feel more comfortable. Guiding a patient through lactation correction, managing nipple trauma, and normalizing newborn behaviors reinforces the essential role of a lactation consultant in early postpartum care. Of course, I would also encourage the mother that she is doing her best and that a fed baby is best, whether that is with supplementing with formula or using a breast pump. Any fed baby is best. I would also encourage the mother to come in if she has any other questions and to reach out if she has any further concerns about her baby's latch. I would also want to have her demonstrate with me during the time of the consultation on how to properly latch to see if there's any difficulty and to correct those techniques in real time. And hopefully by the end of the consultation, Maria would leave feeling more confident and more empowered during her breastfeeding journey, and that I would have helped her throughout this process.